Hey, so hello, and thank you for joining Civic's monthly Change Agent Chat. I am Anna English, a Civic CEO. Before we get started, there are just a few housekeeping items to mention. The phone lines are muted, and we will be using the Q&A feature to field any questions and allow you to make comments on the discussion. So we'll be continuing to monitor those throughout. Questions posed will be answered during the Q&A session. And again, this webinar is being recorded and will be posted to the Civic site, so you may access the information again at any time without any cost. Okay, and so with that, we'll go ahead and get started. Today, we will be speaking with Dr. Jay Want. He's the Executive Director of the Peterson Center on Healthcare, which is a nonprofit organization dedicated to making higher quality, more affordable healthcare a reality for all Americans. Dr. Want is Civic's former CMO and founding board chairman, and I do have to say that Jay, we miss you here in Colorado and especially here at Civic. So Jay, the Peterson Center has a number of great programs and initiatives, and such as monitoring the U.S. healthcare performance and finding and accelerating healthcare innovation, just to name a few. But today, what we want to do is chat about Jay's first year in his new position and the Peterson Center's Data Transparency Initiative. Needless to say, it's a topic that is very near and dear to Civic. So with that, Jay, I'll turn it over to you.
Oh, great. Thank you, Anna. It's a thrill to be on this. And it's kind of weird being on the other side of it since I used to do these from your chair. But hello to everybody in Colorado. I miss you all as well, and I miss Civic especially. But exciting time here at the Peterson Center too. So you kind of heard the intro blurb on the Peterson Center, but I wanted to do a little bit more background, just to give context basically to the data part that we're going to talk about in the middle at the end of this. So the Peterson Center is a part of the Peter G. Peterson Foundation. So P. Peterson was, he just died in April, but he was an American businessman and actually was Secretary of Commerce under Nixon, but probably his biggest claim to fame was that he was a founder of Blackstone. And in 2008, sold his portion of Blackstone for about $1.9 billion. Soon signed on to the Giving Pledge that Bill Gates and Warren Buffett and others have. And so he had put about $1 billion aside basically. And his big cause was basically trying to restore some kind of fiscal sanity to the American and the federal budget, basically, because he thought, man, I'm the son of immigrants. I grew up as a kid behind a cash register in Kearney, Nebraska at an all-night diner, and I got to be Secretary of Commerce, and I got to have this great career. Other people should still have that, and he became worried that it wasn't going to happen so long as we were kind of deficit spending at the rate that we were. So they set up the foundation in 2008, and very quickly the analysts there said, well, we've got to have good news and bad news. I mean, the good news is I think we found your problem. The bad news is that it looks like healthcare is going to be about 70% of the increased debt and deficit over the next 20 years. So you're going to have to get at that if this is going to be successful. So they set up the center in 2014, and we've been looking basically for those solutions that not inventing new ones, but finding them around the country, models of care that actually have been proven to lower cost, but also improve quality and patient experience at the same time. This fits a lot with how Pete saw the world. He thought, well, that's all I did about Blackstone was find good ideas, invest a lot of money in them, and then kind of make them just the way everybody did business in a particular industry, and that's how this works. So why can't I do that in healthcare? So that's what we do, is we actually kind of find these models. We're working in primary care. We're getting started on high needs at this point. We did basically a white paper with the National Academy of Medicine and about 5 other foundations on, kind of what are high needs, what are the segments, what are the potential solutions, and looking for those models now. We'll also be working in serious illness, advanced care, end-of-life care in that space as well. But one of the things that Pete always kind of knew about this is that it's really hard to judge value if you can't actually see any of the prices involved with any of this stuff, and that's kind of a core problem in American healthcare. So we started out at the center basically kind of highlighting variation across the country, working with Elliot Fisher at Dartmouth and with an institution called the Institute for Healthcare Metrics and Evaluation in Seattle. And, lo and behold, no surprise to the people at Civic, no surprise to me, because I saw it when I was there. There's a lot of variation. I mean, big differences in prices between different parts of the country. But we have a distinguished kind of advisory board, and we've kind of, we check with them kind of periodically on the strategy. And they said, that work is great. We really love that work. But until you actually get into local markets, until you actually help people purchase differently and help purchase for better outcomes as well as lower cost, it's kind of all for naught. I mean, it's good to know that there's variation, but at the end of the day, you want people to take action. And again, that's another theme from Pete and now his son Michael, who runs the foundation and the management company at the center. So I combed through my memory and I thought, gee, what places have data? I mean, like real prices on what's going on in local markets, and who could, basically help people understand that better, particularly employers, purchasers, others. And so we started to look into the all-payer claims databases, the APCDs. Civic obviously hosts one, but there are, probably almost 24 across the country now in various stages of development. We think if we can help enable those organizations to have some of the capabilities that Civic has, that Maine has, that other places have, that people will start to take action. And Anna and I were just talking before the call started that sounds like something exactly like that is starting to happen in Colorado, where people say, my gosh, we've been very, very patient with you in healthcare in terms of, you telling us that you were going to reform yourselves, but I got to tell you, we're out of money basically to pay for more stuff that you want to sell us. We'd like to get better value now. So let's kind of dig deep so that we're actually dealing with real numbers and real data and a real sense of, what's more expensive than what. We think, and we hope, very, very much hope, that will happen in states all across the country. And so kind of getting the APCDs up to a level, basically, because they're very different levels across the country, is now becoming a priority for us. We're guided by that sense of practicality, basically, and so we don't know of many other places where that local data is actually available.
So Jay, so you also worked, and needless to say, we'd love to work with you in the Peterson Center, with the data out of Colorado. So we'll talk later. Yeah. But, so with some of the work, and you did some great work with NQF, the National Equality Forum. And so what are some of the performance measurements that you're seeing, can really help and effectively change behavior? It's trial and error for us here, at least in Colorado, and we work with a lot of the other APCDs, but what are you, from that global and nationwide perspective, what are you all seeing?
That's a great question, and we tried to answer that and a few other questions several months back. We actually commissioned some papers from some national authors, basically to try to address 4 different areas, but one of them was data transparency. And we had a convening with some of the best people we could find to ask the question you just asked, Anna, is that, well, basically what metrics actually drive performance? So they came to a number of different conclusions. None of them was a direct answer to that question, but one of the conclusions is, well, we have a bunch of measures. Hardly any of them actually drive performance. Peter Pronovost was actually on the panel out of Hopkins, and I think he's now at Optum. But he said, I'm the chief quality officer for the Johns Hopkins system. You know how many metrics I'm responsible for in some kind of pay-for-performance way? He said 1,400. He said, what's the likelihood I'm going to be able to pay attention to 1,400 metrics? He said, of course I don't. I pay attention to the 2 or 3 dozen that make a big difference to us financially, and those are the ones I really focus on. But the rest of the discussion group kind of said, well, I think what we ought to do, and they weren't uniform in this answer, but this was the kind of majority opinion. Maybe we ought to get out of the micromanagement business. Maybe we ought to be talking to a system like Hopkins and say, well, there are a few things that we want to measure, and here are the metrics we're going to use. Of course, total cost of care. Maybe using the Health Partners methodology that Civic and others helped pioneer. we want to look at some kind of global sense of patient satisfaction. How happy are patients with this? And that means development of more kind of patient-reported outcomes, not simply kind of CAPS, but more detailed stuff, basically, where we can really understand what the patient experience looks like. We want to look at how, what provider satisfaction looks like, because, big correlation between how well providers find the experience and how well patients find the experience. And then quality probably being the toughest of them, because, a lot of those 1,400 measures are purportedly quality metrics, but they don't really drive performance. But the general philosophy was, let's start with very high level stuff and then say, listen, you health system, Hopkins or MedStar or anybody else, we're just going to measure the top stuff. We're going to clear out all the stuff underneath, and then you can decide basically what you want to measure internally in order to be able to drive to the larger goal that we have. So the head of that, the author of that paper was Helen Burston, who was the head of NQF for a while. And she was one of the strongest voices to say, yeah, we have way too many metrics. We validated a bunch of stuff. We need to simplify this to a few different dimensions that we could get down to measure how a system is doing overall, and leave it at that. Let's stop measuring micro stuff that people actually, doesn't really mean there's a good or bad quality performance. It just means that it's something that we have a data source for and that we know how to measure.
So one of the things that, we hear a lot when they think of data, healthcare data transparency, they think about price, naturally, but it's also utilization. Yeah. And, as you're aware, Colorado has been involved in this benchmarking study, this multi-state benchmarking study, of which, yes, we do Colorado compared to the 5 states. We have a facility hospital pricing issue on the inpatient side, but utilization, outpatient and pharmacy utilization was extremely high compared to these other states. So, how is the Peterson Center looking at transparency beyond price?
Yeah, it's a good question. What we're asking is utilization still important? And so a couple things on that. One, some of the work that we commissioned with the Institute for Healthcare Metrics and Evaluation said, well, yes, there is a utilization component to the rise in cost over the years, but the biggest component is actually pricing. It's actually for the same codes. It seems like we're paying a lot more than we did 5 years ago or 10 years ago. Now, we're not able to actually separate out the formal names are price and intensity. We don't know whether in the same DRG people are doing a bunch more stuff for the same bed day that they produce. But the data seems to indicate that pricing is a big deal. Having said that, again, from the opinions of a lot of the experts who sat around the table and discussed this with us, they said, but listen, you got to continue to work on utilization, and the variation that gets highlighted in national databases and also at CIVHC are really important on that. So we continue to work on how does the system get more effective and more efficient. In our primary care work, one of the things that we're recognizing is a big kind of leverage point or a tool. The one that seems to matter most actually in terms of overall cost as well as quality and patient satisfaction is how tight are the relationships between primary care and specialty care? How tight are the relationships between primary care and behavioral health? Those are things that actually, when we looked at exemplary practices through a study that Arnie Mills' team did for us at Stanford, those were the things that actually predicted what, some of the characteristics that predicted the highest performing function on cost and quality were actually the tightness of those relationships. So we're doing, we're starting some work now to try to figure out, well, how would you do that then? How would you actually select specialty providers that you can work particularly well with, that you have a rapport with, that you basically have good communication back and forth with, and then how would we foster that in systems that don't have that particular property? So we think that may be really important just in terms of optimizing utilization. It's really hard to tell what the optimal level is, but we do know some places do a lot better on cost and a lot better on quality and have very low utilization, and potentially they could teach us, all the rest of us, how to do that better.
Great. Now, you mentioned APCDs, and of course, that's a big important database here in Colorado and yes, source of information. So how do you at the Peterson Center intend to engage and work with, not only CIVHC, but other, APCDs throughout the country?
Yeah, it's still formative at this point because we just made this pivot from the national strategy to a more regional strategy probably 3 or 4 months ago. I used whatever knowledge I could import from Civic, but I came here to say, well, there are, kind of trade organizations. So working with Denise Love at NATO, and basically trying to find the commonalities among the APCDs and specifically also what things are missing from a lot of those places. So I think we're going to be kind of in information gathering for a little while. I mean, just kind of trying to get to know you guys better, trying to get to know NATO better, and then we'll try to formulate how we can be helpful. Philanthropy is a great place, basically, because there's some things there are some bets that you can make that other entities cannot. Other entities tend to be more focused on short-term return. We can make 5-year bets and 10-year bets, but despite that advantage, philanthropy only has its a particular niche. One of the guys on our advisory board is Bill Gates, and he's quoted in I think in Forbes at one point saying, well, philanthropy is 2% of the economy, government is 30%, and the rest is private enterprise. Each one of those sectors has its role to play, and so we're excited to be able to be impactful, but we also have a good a sober sense of the limitations of what we can do.
And so before we open up, we've got a couple minutes before we open it up for questions, and I see that they were starting to get some questions that pop up. So please, all of you that are listening, get your questions on the board, and we'll go ahead and try to answer as many of them as possible. So Jay, if there was something, and again, you talked about long-term, the next 5 years or so on, but if there are certain things that can be done now, what would be, based on your experience and with the Peterson Center, what would be your recommendation of what action should be taken now?
And so fill in the rest of that sentence. To do what? I mean, what's the goal therapy for these short-term actions?
To start affecting change, so in order for us to have the right type of information, falling under data transparency, but with the right type of information, what should be those priorities, based on what you're learning across the nation as well as prior experiences?
Yeah, the wonky part about that is that the information is not as transparent as we would like, and it's not as complete as we would like. So believe it or not, we do talk about Liberty Mutual versus Gobea a little bit here, and about how the self-insured is a big chunk of data that actually would be helpful, that potentially some additional action would be nice in order to be able to get those folks into the pool. So this is way arcane detail, but that decision is at the Department of Labor, and so there's a question about whether people should be recommending that Department of Labor exercise some jurisdiction there. I didn't mention in the beginning, but the Peterson Foundation, because of its focus on fiscal responsibility, is primarily a policy shop. So the foundation actually has a lot of relationships with people in DC and with a lot of agencies there. So that's potentially a place where we could be helpful and make some kind of difference in the availability of data. The emergence of data standards is probably also really important. Just like the work that Civic did with the other 4 APCDs under ENRI's tutelage, having basically standard definitions for all this, or standard metrics, ways of measuring stuff, is pretty important. We're finding it is still kind of the Wild West just in terms of what definitions people are using, and there doesn't appear to be a great deal of standardization. So being able to come up with, say, for example, to agree on the Health Partners total cost of care measure as the way we will measure at every kind of level of aggregation, at the practice level, at the system level, at the regional level, that would be really helpful, I think. So those are kind of the infrastructure things that I think might be helpful in order to be able to allow actors on top of that to be able to take action in the local markets.
Great. Okay, so with that, we see that there's some questions that are now coming up. So the first one, I think that we talked a bit about price variation, which is one, and needless to say, premiums are driven by price and utilization.
Yep.
And I think you already addressed some of this. Are we analyzing utilization as closely as price variation? This brings patient responsibility into the equation.
Yeah.
And they also state that there's two local hospitals that drive down costs, but utilization goes up then. And sometimes eclipsing dollars saved from competitive pricing. So we have, it's more than just the baseline question, but I don't know if there's anything that you want to add beyond what you had already addressed regarding utilization and the impact of price versus utilization.
Yeah, there have been other observers who have had that same concern. I don't know who asked the question, but thank you for the question. Some people have made exactly that observation, though, that as you squeeze one end, let's say you squeeze down price and you regulate price, that suddenly utilization goes up. Maryland had that experience basically with the way they paid for a while. Let's say you do the other thing and you say, well, let's control utilization really tightly, and then you watch prices go up. That's pretty much the story of most managed care markets, for the last 20 years. So some places that are starting to think, well, maybe we don't talk about those components, but we set an overall budget basically. So Rhode Island is now considering doing exactly that, to say, okay, we get the whole balloon squeezing problem. When we try to fix Medicaid, prices in commercial go up, or we try to fix commercial and people cost shift someplace else. So let's do this. Let's go all in, see what we spend as a state in Medicare, Medicaid, basically all kind of lines of business. And then let's try to make that as a budget so that we don't exceed the growth of the economy in the state. They're doing that partially by, so underneath that initiative, they're also increasing their spend in primary care and targeting a certain percentage of spend to go to primary care. And they're also putting a limit on how much providers can increase their charges year over year. And so early on, I think the results there are kind of promising, but it's still pretty early. So people are thinking maybe we do stop the squeezing of the balloon in one place to have a pop out in the other by controlling the overall spend and not simply either utilization or price. And
otherwise termed as whack-a-mole. You kind of keep hitting it and something else pops out somewhere else. And I think one of the, those of us that have been in healthcare for a long time, and we've all seen the ups and the downs of fee-for-service versus capitation, but now, you're really looking at the creativeness that is coming out with the various types of alternative payment models. And, some of them are tied straight to quality performance. Others are more of these global type payments versus the legacy capitation. So, I think there's a lot of innovation that's going out there. The question is, okay, what's working versus just another cycle? And I think that's what everyone is working really hard. We have some more questions. Here's another question from Michael Promenko. So he asks, what are the most effective tools, if any, that we are seeing to enlist the help of the patient to help with pricing and utilization?
That's a great question, Mike. And Mike always has great questions. I love discussing with him. So Mike, I think that the at least what we observed in the Stanford study is actually shared decision making is one of the best things. It is unfortunately really hard, though. I mean, it's among the exemplary practices that we looked at, it was one of the most difficult things to install. I think there are a bunch of other things, mechanisms by which people are trying to get incentives aligned basically for on the patient side, and some of those are effective. Some of them are probably blunter than I would like. I mean, kind of the high deductible plans do make people shop. I mean, they do make people try to compare price, and obviously they have financial responsibility in that case. But, the general theme that we're kind of working on is, again, relationships are maybe the most cost-effective thing that there is. That basically, and there's literature to support this, that trust in a particular provider is one of the best things you can do for cost and quality. So if I had to give one answer, Mike, I would say that the shared decision-making may be the most promising thing that we see right now.
So I see that Michael has another question. I'm going to switch over to George Swan, who we've all interacted quite a bit here in Colorado. So hello, George.
Yeah.
You know, George asks also regarding, you know, he was looking at the Peterson Center site.
Yeah.
What about adding other types of data sources to, you know, these, not, you know, I'm going to add a little bit, you know, not just necessarily at the Peterson Center, but also some of these other healthcare data sites, such as Civic.
Yeah, good to hear from you, George. Missed our conversations after the commission. I think that's ultimately where this has to go, and an area that we're interested in are patient-reported outcomes. Actually, not simply kind of measuring satisfaction, but what the experience was like. It's going to take a while, basically, to incorporate that kind of data into to basically meld administrative data with clinical data with patient-reported outcomes to get a more granular and complete picture of clinical encounters. We don't anticipate being able, or we haven't seen anybody yet who has been able to do that on a large scale. But you know, I would guess 3 to 5 years we'll see a lot more of that. Particularly in the patient-reported outcome space, we're working with Northwestern right now on a pilot on that and how to embed that basically into their electronic health record. But the space is still pretty early, I think, at this point.
You know, so another question that came up, which I think is very, very pertinent. You know, there are a lot of requests for the systems, for the providers and the hospitals and the physicians to change, the health systems themselves. But what do we need to do to get, you know, to ask for more engagement from the patients? You know, so again, a lot of it is tied to the benefit plans. But just like it's a lot of trial and error. How do we actually get engagement? I think it's a great question. How do we actually get patients to engage and say, it's okay to ask questions. It's okay to ask about price. It's okay to ask whether or not they really need that test.
Okay, so you mean normalizing that?
Yeah.
Yeah.
I'm sorry, what?
Well, I was trying to discern exactly what kind of engagement. I mean, normalize the ability to talk about price and basically to not have people not be embarrassed to say, you know, doc, I got a $5,000 deductible, and this is pretty much, you know, this is a good chunk of my savings basically if I have to pay for this particular test. And so, you know, do I really need it, or do I, you know, is there something cheaper that I can go after? That is a larger cultural change, unfortunately. But I think we're kind of at that place where, you know, I think people are out of money, and so I think it's going to become more normal to ask about that. Certainly, providers are telling me that they get asked the question more and more frequently. I think one of the keys to motivating people in general on these kind of topics is that, because we've struggled with this, you know, boy, I'd like to lower the percentage of GDP spent on healthcare. Doesn't make a great bumper sticker. So we're kind of toying with the messaging around this, and we think that one of the things that may resonate is, you know, I've tried to reduce it to a phrase: care people can't afford isn't care at all. So basically, as long as the prices continue to go up like this, and as long as more responsibility gets pushed off on patients, then it's threatening access. It's threatening basically our ability to take care of an entire population of people. And so I think if people want to embed something basically in their message so that they don't feel so sheepish about this, I think it's that care I can't afford isn't care that's available to me. So help me get care that is affordable so that I can actually do what you ask me to do, or what we decide that we should do for me together.
Well, I have to say, this has been a wonderful discussion, but we are at the end of our 30 minutes. So thank you, Jay, for joining us and sharing your valuable insights. I have to say, you have gained a lot more insights. Hopefully you carried a lot with you from Civic and your time here in Colorado. Thank you to all of you that have joined us as well. The recording of the discussion will be shared via social media and the Civic site in the coming days. Our next chat is Tuesday, August 28th, when we'll be chatting with the Coalition to Transform Advanced Care. and about their national summit that is coming up in Colorado, and it is right here in Denver. A very important topic. I know it's a very important topic as well for the Peterson Center and for Jay as well. Thanks again, and have a great weekend, or a great week. Thank you.
Great to talk to you all. Bye-bye.